Hi everyone, welcome back to my channel. So today we're going to be talking about strokes. So if you're new here, hi, how are you? My name is Gabby. I'm an ER nurse and I love teaching, and this is why I do these videos to help you guys, because I remember when I was a nursing student and nursing school is not easy. So I'm sorry if you hear my baby in the background. She's playing again. So you might hear her throughout the video and I'm very, very sorry. So, like I said, we're going to be talking about strokes. I tried to make this presentation as condensed as possible to include the most important things and for you guys to understand strokes in general. I don't want to overwhelm you with so much information because there is a lot to strokes in general. Like for example, like right now I'm in school and I'm going back for my acute care nurse practitioner license, and we had neuro week, and I swear to you, I was like, what the heck is going on? Because there were so many types of strokes, and like the questions were like, if a patient presents with this, where is the stroke located in the brain? And it was a mess. Okay, so if you're in nursing school, you don't need to go that in depth. So I condensed all the information for you so you do not feel overwhelmed, because I know how bad nursing school is already and I don't want you more overwhelmed. So throughout the video, I'll let you guys know the most important things to know for your exams. But yeah, let's get started. So let's talk about what a cerebrovascular accident is, what a stroke is, so you could kind of understand. And just in case if you have not watched my pathophysiology video of the brain, I would recommend watching that prior to this, because like I always say, patho is very important, and I'm telling you, if you watch that video, you're going to understand a lot of the things that I'm going to be talking to you guys about during this video. Okay, so a stroke is the inability of blood to reach the brain. So remember, blood has oxygen, okay? And your brain needs blood and like oxygen rich blood to function, right? So when there's an inability of blood to reach the brain, there's different causes. It could be due to a blockage, which could be caused by a blood clot or a narrowed blood vessel, or a bleeding vessel, like when a patient has an aneurysm and it bursts and then there's blood everywhere except the brain. Okay, so what causes a stroke? So I want you guys to take out your favorite color highlighter and write this down and highlight it to the T, because I'm telling you that you will have a question on your exam about this. Okay, you will have a question that asks you, what is the number one risk or the number one cause of strokes in the United States? And the answer to that question is high blood pressure, especially uncontrolled high blood pressure. Okay? Please, 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 please remember that. This could also be a select all that apply question. So make sure that you learn these four causes like it was your favorite song. Recite this in the bathroom. I don't know how you guys remember this stuff, but I'm telling you, please, please, please remember this, okay? So high blood pressure is your number one risk factor, and after that, we go into smoking, because smoking could cause clots, but also it weakens your blood vessels, okay? Hyperlipidemia, I hope I'm saying that right. Don't judge me with my accent. But high cholesterol, it causes narrowing of the blood vessels. And uncontrolled diabetes. So the reason why uncontrolled diabetes is one of the causes is because when a patient does not control their diabetes, their glucose levels in their blood start shooting up, right? And that glucose buildup starts becoming like a thick layer in your blood vessels. So it kind of does the same thing as high cholesterol, where it narrows the blood vessels and then it causes ischemia. So we're going to talk about the different types of strokes. We're going to talk about the three major types. So remember, I am talking about the three major types, but if you decide to go back to school and get your NP, you are going to be dissecting those three major ones and learning different types of strokes within those categories. For nursing school and for the real world right now, I want you to know these three types of strokes, okay? As long as you know these three types, you will know how to manage your patient the way that they're supposed to be managed, okay? So the first one is your transient ischemic attack, which is a TIA. So I always think that this is kind of like a, hey, heads up, you're at risk for a stroke type of thing. It's like it happens, but it's not a full-blown stroke, okay? And the name of it kind of like tells you what it is. So you have the transient, which is the small lack of oxygen that lasts a short time frame, and then ischemic, low oxygen to the brain, and attack. It happens suddenly, it comes and goes, and can resolve on its own. So, for example, you'll have a patient and they'll come to the ER, right? And they're like, I had some trouble speaking today. I was trying to talk to my sister and I was thinking of the words and I couldn't tell her what I wanted to, and it lasted about like 2 to 3 minutes, and like I had like slurred speech as well. And the sister tells you, yeah, it like literally lasted like 2 to 3 minutes, and then like all of a sudden she was talking normal again. Okay, these are your TIAs. The symptoms just resolve on its own, and it's very like it just lasts like a few minutes and then that's it. It's like it never happens. With this, it's because of that low oxygen to the brain, where kind of like the brain is like, whoa, I'm not getting the oxygen, so it kind of like stops working. And depending on where that ischemia is occurring, the patient will have the different symptoms. Now, for your ischemic strokes, we're thinking about that there's no blood flow, okay? There's no flow to whatever part of the brain it is, right? So when you're thinking about ischemic stroke, think about a clot, think about a blockage, something that is not allowing blood flow to that specific part of the brain, okay? This is a decrease in perfusion to that specific part of the brain, which causes low oxygenated blood to go there. So the brain is not going to function in that specific area because it's not receiving oxygen. Okay, so there's two types of ischemic strokes, and that have to do with clots. So you could have your thrombotic stroke, which is the narrowing of blood vessels in the brain that leads to blood clotting, which leads to then blocking and causing severe reduction of blood flow and oxygen to the brain area. So basically ischemia. Okay, and then you have your embolic, and this is the one that, like, let's say that the patient had a DVT or had a history of a DVT. That clot got dislodged and traveled all the way to the brain. So I will be posting a video about DVTs and stuff, but when clots travel, so let's say that you have a clot in your leg, it could either get stuck in your lungs or it can make their way all the way to the brain. And I mean, it doesn't necessarily have to be in the legs, but I'm just referring to, like, if a patient had one there and it got dislodged, it could go anywhere in the body, but it could get stuck. Okay, and then in these cases, the clot gets stuck in the brain, causing a blockage, and then the brain again does not receive the blood that it needs. Sometimes, if you look at the blood vessel, the clot could be like somewhere like in the middle here, and you could still get like a little bit of blood going through it, like if something was in the middle and it's like trying to go through. But the brain still needs that adequate amount of oxygen. So sometimes ischemic strokes won't cause necrosis all the way, but it eventually will if it's not treated. Okay. And then the third one that I wanted to talk about is the hemorrhagic stroke. So this is your bleeder. This is the one that you need to control because the patient is bleeding for sure from somewhere. So this could be caused by an aneurysm, trauma, uncontrolled high blood pressure, and the patient will come to the hospital and tell you that they're having the worst headache of their life. This is because if you think about it, the blood vessel bursts, blood is going where it's not supposed to go. That's going to build pressure in that patient's brain, and it's going to start causing high intracranial pressure. Okay, so make sure that you know your signs and symptoms for high intracranial pressure. I will be doing a video just about that sometime this week. But do know that if you get tested on hemorrhagic strokes, they might put a question about what your signs and symptoms of high intracranial pressure ICP is. This is usually in your MedSurg 3 classes, but just in case. So you want to think about a bleed when you're thinking about a hemorrhagic stroke, okay? And this is when the blood vessel breaks and blood seeps out. Now, I wanted to go over the signs and symptoms, and I want you guys to understand that these signs and symptoms can occur in any type of these strokes, okay? This is broad spectrum signs and symptoms. If a patient walks in to the ER with any of these symptoms, you are going to do your NIH regardless of if you think it's a TIA, an ischemic, or a hemorrhagic. Who cares? You won't know until you do a CT scan. So your signs and symptoms, you're going to see that the patient's going to be complaining about, and mind you that not all of these symptoms have to be in the same patient. For example, the patient could have like one of these symptoms, they could have 3, they could have 4, they could have 5, so on. You get the point, okay? So they could come in complaining of unilateral weakness or paralysis, altered mental status, and I want you guys to make sure that if you are working, especially in the emergency room, if a patient comes in and they're elderly, okay, even though you think that this patient has dementia or Parkinson or whatever, if they come altered mental status and their family says this is not their normal, I don't want you to be, like unempathetic, because it happens a lot where we just say, oh, this is probably like sundowning or whatever, and they don't pinpoint what's happening, okay? If the family member is telling you, listen, yes, they have dementia, yes, they have Alzheimer's, but this is not their normal mental status, I want you guys to treat this like a stroke, okay? Sometimes it could be a UTI, an infection, and cause altered mental status. But until you do your NIH and you don't rule that out, and the doctor doesn't rule out that it is a stroke, you are going to continue thinking the worst, okay? Because it's better to think the worst than think not the worst, and then the worst is actually happening, okay? And you're here to save patients, right? So your patient can come in with altered mental status, a facial droop, slurred improper speech, vertigo, dysphagia, and unequal pupils. Okay, so these are very, very common symptoms, and mostly the ones that you will see with your stroke patients. So I want you guys to think about BFAST. This is something that I memorized in nursing school, and now I use it without even thinking about it when I get a patient that comes in for a possible stroke. Okay, this is going to allow you to ask the questions that are needed, okay, while you're assessing your patient. So you want to assess their balance. You want to see if they're having any issues walking, if they have any like unilateral weakness, clumsiness, etc. For their eyes, are they telling you that they're having visual problems? Did they go blind in one eye? Are they seeing something abnormal that they've never seen before, like floaters? Whatever the case is, just make sure that they haven't lost their vision, the visual changes haven't changed. F is for face. So your face, you're looking for symmetry. Are you seeing any like drooping anywhere? Can the patient smile? Can they close their eyes tight? Etc. For their arm or leg, same thing. Are they able to lift their arms against gravity? Are they able to do it by themselves? Are they able to follow commands and do what you are telling them to do? Okay. a lot of these things go hand in hand. So while you're assessing your patient and you're talking to the patient, you're also assessing their speech. You're assessing if they have receptive aphasia, if they have expressive aphasia. You want to check also their level of consciousness. Can they tell you the date of birth? Their full name. And then you're thinking about time. When did all of these symptoms start? This is very, very important, because this is going to determine if you're going to be calling a priority 1, if you're going to call a priority 2, if you're going to be able to give certain medications, if it's a hemorrhagic stroke that we'll discuss later on. Are they able to go to IVR, things like that. Okay, so just make sure that you think about BFAST when it comes to your stroke patients, and those questions that you're going to be wanting to know and ask your patient, because on your exams as well, you are going to be mostly like asked, if a patient arrives to the hospital, like what things are important to ask. And one of the things that they always ask you is if you ask the patient, when did all these symptoms start? Okay, that's very, very important. So I did want to touch briefly a little bit on like the differences between a left-sided and a right-sided stroke. This is actually asked a lot in MedSearch 1. I remember being asked on a test what the difference was. So make sure that you know the difference between the left-sided and the right-sided strokes, okay? When you're dealing with the left-sided strokes, you're having issues with dysphagia, you're having issues reading or writing problems, and then you're having right-sided body problems. So I'm physically seeing that you're having right-sided neglect and hemiparesis and weakness and all that stuff, but the stroke is actually on your left side of the brain. So your left-sided stroke will reflect on the right side of your patient, okay? And then for your right-sided, it will reflect on your left side of your patient, where they're going to have the left hemiparesis, the left side neglect. They're going to have behavioral changes, so they could actually get very aggressive, or they could get emotional. Whatever the case is, they have behavioral changes that are not their norm. And they also have a lack of impulse control. And this is something that we're going to be talking about at the end, is how to educate your patients, family members, to understand what's happening, because they're going to see their family members in this way that they've never seen them before. And that's just going to cause anxiety, and it's a lot. So just remember that for right-sided strokes, they will have like a behavioral change that's not their norm. Now, for diagnosis, our biggest thing is a CT of the brain with no contrast, and this is done immediately. I'm telling you that this patient comes in. This is why it's so important to know about your strokes, how to assess, how to catch them, because this has to be a 1, 2, 3. Patient comes in with one symptom and you're already thinking, oh, this could be a stroke. While you're talking to the patient, you're doing your NIH, somebody's popping a line, somebody's doing blood, somebody's checking glucose. Everything is happening very, very fast. Okay, so on your exams, just make sure that you know that the main diagnostic exam is a CT brain non-contrast. And this is literally like the patient should be from entrance going straight. If your patient comes through an EMS, literally we're meeting them in CT. That's how important a CT brain is. Now, depending on what we see in that CT brain, if we don't see a clot, and the neurologist that meets us in the CT does like their NIH, and they're like, yeah, I think this might be if the CT brain does not show a bleed, I apologize. If it does not show a bleed and the neurologist does an NIH and they still think that this is a stroke, we go ahead and we do a CTA. This is a CT with contrast. So we'll check the creatinine level at bedside with the patient at bedside, because obviously we have to give them contrast. And then we give them the CTA, and then the CTA will help us to see if there's a clot. Sometimes when the CT and the CTA are negative, but the patient is still having an NIH, of like an abnormal NIH, we move ahead and we admit the patient for an MRI. But for your test purposes, your question is mostly going to be on what is the main diagnostic exam for strokes, and your answer is going to be CT of the brain, non-contrast. So I wanted to go over the NIH. I personally don't have this memorized. It's very hard to. I don't think it's necessary either to memorize it for class. But I do need you guys to know like what it entails. I need you guys to know how to use it, because you might have questions in regards to the NIH, and things that are inside, like for example, like what does an NIH look for, and you need to know that it's assessing like the level of consciousness, the patient's gaze, their any facial paralysis, like the movement of the body and things like that. But you don't have to be specifically, memorizing each thing. So when you're doing an NIH, you're kind of doing this briefly, and the NIH kind of tests for different things. And once you're done with your NIH, it kind of like tells you like where the stroke might be happening in the brain, which is why I was telling you guys to listen and see the video that I said about the different lobes of the brain and what each lobe has or does. So for your NIH, you're going to be checking the level of consciousness. When the patient arrives, is this patient alert? Are they drowsy? Are they not even responsive? Can they tell you what month we're in? What age they have, what their date of birth is. You want to see if they follow commands. Do they open their eyes, or do they respond to you when you call their name? Their best gaze, are their eyes open? Do they only open with pain? You want to check their gaze as well. So when if their eyes are open, you need to check to see if they could follow your fingers, and see if they could follow that, like if they have a gaze or if they have a neglected side. So a lot of these patients that are having some strokes, you'll move your fingers and tell them, hey, look, follow my finger, and they won't cross over to the other side of their body. Also visual, can the patient look to the side? Can they tell you? I would recommend you guys looking at a video of somebody doing an NIH, because it's a little bit hard for me to explain. But there's like there's an exam that we do for the visual that they have. You cover like one of their eyes, and then you hold up like different numbered fingers. So you'll either do a 2, a 3, or 1, or whatever. And then you'll basically go in the 4 quadrants of their face and see if they could tell you how many fingers you're holding up. And it's very important for you guys to watch a video so you guys can understand what I'm talking about. Then your facial palsy, can they smile? Can they raise their eyebrows? Can they squeeze their eyes? A lot of the reasons why we do this as well is because we're trying to rule out also Bell's palsy while we're doing the NIH. And then after that, we're kind of looking at the motor functions. So you're going to check for motor function of the arms, the legs. You're going to look at limb ataxia. Can they follow, can they touch their nose and touch your finger? Can they do like the heel down shin exam? Then we're going to look at sensory. So you're going to be doing that and asking them to close their eyes, and then you're going to touch their right foot, and you're going to say, okay, what am I touching right now? And they should be telling you, well, you're touching my right foot. I could feel it. Sometimes they won't feel anything. So you want to check if they could feel anything. And if like one side is more, if they could feel one side more than the other. And I like doing this with their eyes closed, because you know for a fact that if their eyes are closed, they will answer correctly if they're actually feeling it. Then you're looking at the best language. Is the patient able to speak? Can they name the items and the things that you show them? So in this case, we're going to be showing them like a picture and telling them if they could describe what they see. We're also going to have them like read a sentence and see if it happens. If they wear glasses, make sure that they're wearing their glasses, because that's not fair. And then we're going to be evaluating their speech as well, by repeating words, and seeing if they're able to do that. And then lastly, we're going to be checking for extinction and inattention. So a lot of these patients, they will forget that they have a right side or a left side. So they'll be like, I don't know how to explain it to you guys, but the patient will basically like only like raise their left arm, and they won't cross over to their right side of the body. Like I said, it's very important for you guys to watch a video on that so you guys can understand what I'm talking about. But it's very important for you guys to kind of know more or less how to do an NIH. Now, for interventions for a positive clot. So this is if the patient gets a CT or the CTA and there is no bleed, but there is a fat clot. Okay, it doesn't have to be fat, but they're usually big. Anyways, so if the patient has a clot, we could use a clot buster. Okay, those are a thrombolytics. Those are your TPAs, your alteplase, your streptokinase. But you need to make sure that this has been given within 4.5 hours or less of the onset of symptoms. Okay, so that is a test question. You cannot give this medication past 4.5 hours of the onset of the symptoms. So not when the patient arrived to the hospital, okay? The onset of symptoms. So if the patient was last seen normal 7 hours ago, you cannot give this medication. Okay, it is very important that while you're going to CT, usually the stretchers are weighted, but make sure that you have an accurate weight for your patient prior to this medication, because it is a weight-based medication, and too little or too much of this medication could harm the patient. Okay, you also need to have a normal INR, a blood glucose, and platelets. I didn't mention this before, but the reason why we do a blood sugar when the patient arrives is because hypoglycemia can mimic a stroke-like symptoms, okay? So it's very, very important that you check, is this patient in hypoglycemia or is this patient having a stroke, okay? So that's why we check blood glucose as well prior to, while we're doing everything. And then you also want to make sure that your blood pressure is controlled, okay? If this medication is given, it is a thrombolytic. These patients are at risk now for a bleed. So now you have to be monitoring for bleeding, hematomas. Now you have to check if the patient starts complaining of a headache, like the worst headache of their life, because they might have an intracranial bleed. You want to check their HNH, checking their hemoglobin, and making sure that their hemoglobin is not sinking down. You want to look at your clotting factors as well. It is very important to put these patients bed of the head of the bed increased with the headline and midline to increase like the perfusion of their blood. And after this medication is given, this is why it's very important to get your IVs in place before this happens, because after this, no new IVs or injections can be given, because this patient is at risk for bleeding. Okay, unless an emergency occurs or whatever, you need to try to not put any other IVs or injections in this patient. Now, I did put that you need to do your vital signs Q every 5 minutes. There is a full like rundown and a whole packet that when you initiate the TPA, you have to do vital signs like every 5 minutes, and then it goes every 10 or 15, and then every 30. and so on, until I believe like the first 24, 48 hours or 72 hours. I'm not sure. They won't ask you that, but just for clinical purposes, if you ever get floated to the ER, or you become an ER nurse, or you get to do clinicals in the ER, ask for that packet so you could see what I'm talking about, because it's very, very important to monitor your patient. Now, on your exams, this is what they're going to be asking you. Apart from the time that you could give TPA, what are your contraindications? And this might be a select all that apply question. I repeat, this will be a select all that apply question. Okay, what are the contraindications of TPA? The way that I remember this is, what can the patient have that if I give a medication that causes more bleeding or could cause bleeding, will kill my patient or harm my patient? Okay, if you think that way, you kind of will understand these things. So if a patient had a head trauma or prior stroke in the previous 3 months, you are not going to be giving this, okay? Because if they have already a trauma in their brain, or if they had a stroke, they probably had TPA before, okay? Or there's a trauma in their brain and then you're causing them to have a bleed, most likely. They cannot have a history of a previous intracranial hemorrhage, intracranial neoplasm, AVM, or an aneurysm, recent intracranial or intraspinal surgery, elevated blood sugar. I'm sorry, low blood sugar. I am going crazy. Elevated blood pressure. I'm sorry. So like I said, you have to make sure that your blood pressure is controlled. So the systolic cannot be greater than 185, and the diastolic cannot be greater than 110. If this is the case, this blood pressure has to be controlled prior to giving this medication. Okay, there should not be any active intracranial bleed, of course, because then you're going to make it worse. Their platelet count cannot be less than 100,000, because if there's no platelets to clot, you're just gonna be putting this patient like to bleed. Heparin had if they received heparin within the last 48 hours, do not give this medication either. Current use of anticoagulants. So a lot of these patients are on either Eliquis, warfarin. Warfarin I don't see that much, but Xarelto, Eliquis, those are like very, very common medications. So because a lot of people have had MIs, they've had DVTs, they've had prior strokes, you know, and they've been placed on these anticoagulants. So if the patient had taken that anticoagulant that day, you cannot give this medication. Neither if they have taken their direct thrombin inhibitors, and then their blood glucose cannot be less than 50. Okay, so make sure you guys know that. All right, so nursing interventions. So this is for whatever type of stroke the patient has. You want to make sure that their airway is okay, of course. You're going to keep these patients NPO until the swallow test has been complete and they have cleared this patient to eat. You're going to remove any dentures if they have any, and make sure to, label and, store it or give it to the family member and document it. And then you're also going to be monitoring your respirations on this patient. For the neural baselines, you want to do your NIH, obviously. So you're going to be comparing the baseline NIH, so the NIH that the patient arrived with, and you're going to follow up and you're going to keep doing NIHs. So your NIH, you might get a question on this on the test, okay? So the NIH is done when the patient arrives, and then if the patient has any changes while you are the nurse, and when you receive this patient, and when you are giving shift change. Okay, so shift changes, every shift change, if you work in the ER and your the patient obviously is going to be admitted and you give report, you have to do your NIH, because prior to calling that nurse, you're going to tell them, hey, the NIH is this right now. Okay. And then when that patient goes upstairs, that nurse is going to do the NIH, and then you guys are going to compare the NIHs. If there's like a big change or if something happens, neuro has to be aware, and they might have to stroke alert the patient once again. So make sure that you know for your test purposes when your NIH has to be done, which is when the patient arrives to the ER. So that's your baseline. Then when you're giving shift change, so if you're, let's say if the patient is on the floor or in the ER and the patient still hasn't been admitted and you're an ER nurse but you're done with your shift, you have to do an NIH with that nurse coming into the shift taking over your patient. You also have to do an NIH if the patient gets an admission bed and they get a bed. You have to do an NIH before they go upstairs. And if you work as the neural floor nurse, the same thing. When you give report to the upcoming nurse, you have to do your NIH as well. So make sure that you know that. And also, it is very important that if you're with a patient for 12 hours and you see that the patient's changing and their mental state or something is changing, you're doing your NIH as well. And if there is a change, you have to call neuro, okay? Because they might have to stroke alert that patient once again. You also want to do your mental, your neural assessments. Usually the neurologist will put it like every 4 hours, like Q4 hours. But it depends on how severe your patient is. You want to do your Glasgow stroke. And then you also want to make sure that your seizure precautions are in place, okay? These patients are at risk for seizures up to 24 hours from their initial symptoms, okay? So make sure that your seizure precautions are up at least for the first 24 hours of having this patient, okay? You want to make sure that there are 2 or more IV accesses, so that's why it's very important to have and get these before the patient gets TPA if they do receive it. You want to give them normal saline to maintain or increase blood pressure if it's necessary. And then also you want to make sure that you cluster your care, because you don't want to overload this patient with sensory, okay? The less that you prevent sensory overload for your patient, the quicker that they are going to get better. Okay, so clustering care for these patients is very important, and it's something that you will be asked about in your NCLEX, and this is also going to be on your exams. So clustering care for these patients is essential. Okay. Now, other nursing interventions in regards to feedings after the patient has been cleared by the swallowing exam. And if they are clear, make sure that these patients flex their neck while they're swallowing. You are not going to be giving these patients sedation medications, okay? The reason why is because you're going to be doing mental exams. You're going to be doing NIHs. You're going to be doing like the neural checks every 4 hours. So if you give like a sedative, which is something that a lot of nurses don't understand, and I've seen it done many, many times, where they give the patient Haldol, they give the patient Ativan, and you're like, what the heck are you doing? Now you can't really assess your patient. Now we don't know if there's an actual NIH change or a neural change, or if it's because of the sedation that you just gave them. Okay, so no sedation medications, something you want to prevent. And you could ask any neurologist and they will agree. Okay. And then if a patient has dysphagia, make sure that a pureed diet is ordered for this patient and their fluids are thickened by the thickening agent. Now, patient education. This is very important. And not only are you educating your patient, but you're also educating your family members. Okay. Because this is just such a hard thing to go through, not only for the patient, but also for the family members. So it is very important that you also show like empathy towards, the family members. So you want to explain to the family and the patient that they should dress their weaker side first, because a lot of the times when patients have strokes and they start having like when after the stroke they had like left-sided deficits or right-sided deficits, we see that a lot of these patients start to neglect that side, that weaker side, and we want to prevent that. So dressing the weaker side first can help them not neglect that side. Also, for safety purposes, you want to explain to the patient that now they have to scan their surroundings even more. You want to have them turn their head to the affected side to make sure that they're not missing anything. And when a patient's family member is going to approach them, make sure that you let them know that they need to approach them on their unaffected side, because remember, if they have an affected side, they might not see them, they might scare them, they might swing at them. So make sure that you educate that and you tell that to the family member. And also, if your patient is having that right-sided stroke, like I mentioned before, educate the patient that behavioral changes are expected, and hopefully they will resolve, but sometimes they don't. But just making sure that you let the family know that this is due to the stroke could help a little bit during this hard time for them. And then I also wanted to mention that as a nurse, you also want to take an account these things in regards to, and not only you, but educating the family member as well, to not, I repeat, to not complete tasks for patients. This is one of the things that they're going to be asking you in your exam, that you have a stroke patient and they need to I don't know, put on a shirt. What is the best thing to do? And the answer is to allow your patient to try to complete the task. Okay, you could assist them, but you want to see if they are able to do this, because they need to be more hands-on with themselves. They cannot lose themselves because of a stroke. It's something that they need to do on their own. So do not complete their task for them. Okay, do not speak loud to them. And also use simple questions, especially right after a stroke. Like, don't go and ask them questions that they have to elaborate, because a lot of these patients are going to be having like expressive aphasia, and that just causes like a lot of anxiety to the patients, because they physically know that they're having issues speaking and they can't come across and say what they want to say. And that causes a lot of anxiety, because I've had a lot of patients cry on me when they're trying to express themselves and they can't physically talk to me. And not only me, like the family members, like you have to educate that, because I've noticed that the family members agitate them as well, because they start asking them questions and this and that, and then they're like, hello, like you're not talking to me, and then the family member just, the patient just starts crying because they can't talk. So sticking to simple questions, yes or no answers. This is another test question. Make sure that you know that simple questions, yes or no answers, are the best questions to ask your patient. Okay. Also, if your patient is able to ambulate, make sure that you're using your transfer belt to ambulate the patients. And when you're transferring the patient to, let's say, like the bed or a chair or whatever it is, always transfer your patient toward their strong side. And that is it for our strokes. So if you guys have any questions, make sure to drop the question down in the comments box. And you guys could also get in contact with me through Instagram. That's my Instagram. So make sure to follow. And if you liked this video and you found it helpful, make sure to make sure to subscribe and also hit the bell button. And that's gonna basically send you a notification every time that I post. And if you guys have any recommendations, anything that you would like me to improve, please drop it down into the comments. I love constructive criticism, and I love for you guys to speak out and tell me what you guys need. I do these things for you guys, and I want to improve as much as possible in order for me to help you as much as I can, for you guys to pass your exams and become amazing nurses. All right, bye.